Welcome to the Expert Perspectives from the Great Debates and Updates in Inflammatory Bowel Disease meeting taking place in San Francisco, March 21st and 22nd. I'm happy to be joined by my colleague, Dr. Joel Roche, who is the Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai Hospital in New York, as well as the Director of the Pediatric GI Division at Goriad Children's Hospital in Morristown, New Jersey. Thanks, Joel, for joining me today.
Thank you, Marla. So it's my pleasure to bring you a recap of a lot of the exciting talks and debates that went on today here in San Francisco. We were started off by Dr. Mel Hyman, who is right here in his hometown. He's at the University of California in San Francisco, who gave us a state-of-the-art talk about the emerging concepts of different phenotypes and risk stratification of the different phenotypes of inflammatory bowel disease. You know, the more we do this, the more we realize that it's just not two neat little cubby holes, Crohn's disease and ulcerative colitis. There are many different diseases that fall under each of those umbrellas. And Mel did a great job at showing how pediatric inflammatory bowel disease is really a prototype to understanding that there are different diseases. For instance, we understand that when inflammatory bowel disease occurs in pediatrics, it's a much more extensive disease. A lot more bowel is involved. For ulcerative colitis, 80% of the patients have the whole colon involved, as opposed to adults where 2/3 of the patients are just left-sided. He also showed that depending in Crohn's disease how much of the bowel is involved, you can expect a different outcome. Patients with ileocecal disease seem to have more of a stricturing course, whereas ileocolonic patients tend to have more of an inflammatory course. There's also an appreciation that the incidence and prevalence of these diseases in pediatrics is on the rise, more Crohn's and ulcerative colitis, and that patients who are young, let's say less than 10, have a colonic predisposition. And the very early onset IBD is a whole interesting cohort of patients, those who present less than 2 years of age. Perhaps there's a greater genetic signal in those young children, and he used the interleukin 10 mutation as a prototype for that, and showing how it's a very specific and very aggressive disease. And they've had 2 of the patients here who've gone on to bone marrow transplant for that. So it was a very interesting talk in getting us to better understand the differences in pediatric versus adult IBD, as well as the idea that there are different types of Crohn's and ulcerative colitis.
I mean, what I took away from it was the fact that we have varying phenotypes of IBD, and pediatric is even a little bit more complicated in that it appears that children less than 2 behave differently than children between 2 and 8, I believe he talked about, or 2 and 10, and then from 10 on it appears that they behave more Crohn's-like. There's much more Crohn's in that population, and that younger tend, as you noted, to be more colonic type phenotype. But what's interesting, what I took away also, was the fact that when we design clinical trials, or when we say anyone who enters a clinical trial has a diagnosis of Crohn's, what does that really mean? I mean, if we're trying to say that there's more than one type of either Crohn's or UC, but yet when we're designing trials, we're saying all Crohn's patients could have exposure to this therapy. Is that why maybe at the end of the day our clinical trials don't have 80% or 100% efficacy? Could you imagine a day where we would actually genetically or phenotypically choose patients, maybe in early concept stage of studies, making sure that that is the right drug for that particular phenotype, and then as you go on to registration trials, which are larger trials that allow drugs to be approved and come to market for pediatrics, we may have more patients responding to therapies than just randomly a heterogeneous group of Crohn's or UC patients. Do you think that would be helpful?
Absolutely, absolutely, and I think you're exactly right. And as we move closer and closer to the day of personalized medicine, I think for those of us who are taking care of the individual patient in front of us, it becomes a very important concept. What is this patient have, and what is actually going on with this patient, so I can better tailor my therapy? I think you're exactly right.
So I think one element is choosing a patient, considering what treatment would be right. And then there was some discussion today. My topic in particular was focused on disease monitoring and this concept of tight control and this concept of once you've chosen a treatment, how to optimize it. So do you feel that there was a particular message that was resonating with the audience, or that you took away from the idea of tight control or disease monitoring plans?
Oh, absolutely. I think you laid out really a very good framework of thinking about how is a therapy best used? What is the target? And I need to pick a target, and then I need to monitor and make sure that I've got good tight control around that target. And whether ultimately the best target are non-invasive markers like stool markers. You talked a lot about calprotectin today, which can be a very helpful non-invasive marker. Or should we really be looking at mucosal healing, and if so, how often and where? Or in pediatrics, where we have growth and looking at linear growth in our patients, especially in our Crohn's disease patients, as long as we pick a target and stay consistent and watch. Another idea that you brought out, which I think is really very empowering, is the idea of who should monitor, and making our patients part of the monitoring so that they can take care of their own disease is a very important take-home that I got from your talk.
You know, it's interesting. People say, oh, patients don't want to collect stool for calprotectin, or they don't want to get an additional blood test. I think it's all the way we communicate to parents and patients, right? If you actually put the dots, connect the dots for a patient, and you explain, 1, you have this kind of IBD, 2, this kind of IBD responds best to this treatment, 3, in order to make sure this treatment's working, we need to have either endoscopically or radiographically, you had mentioned the role of MRI, for example, in looking at bowel wall thickness, or non-invasive ways of monitoring the disease. And then it's important that you connect that next dot and say, once we've gotten down the path of choosing this treatment and we've discussed the risks and benefits of these treatments, we need to be able to optimize it so you can stay on it. Because why just use a drug that's going to fail, or we show that you often need some kind of dose escalation or some kind of dance with one of the therapies in a large proportion of patients, but that's because we wait for patients to fail before we actually say, you're failing, let me check why you're failing. Can we now start to think one step ahead of that and bring patients onto that same page and say, let's be proactive, let's check your stools regularly, or let's rescope you, or let's re-image you after a fixed period of time, and then optimize that drug that we chose for you. So I think we kind of are starting to understand that patient engagement, just like you had mentioned about patient-reported outcomes, is there's some changes in the way we're going to be even evaluating how drugs are working in both adult and pediatric patients. So it's about, I think, everyone being on the same page. Do you agree?
Totally. And recognizing that if we just wait until symptoms, the cat's out of the bag. And probably the best model for that is when we first diagnose our patients. We're amazed at how much damage has already happened to the bowel. But that's when they first come to us with their symptoms. And if we wait to reenact that same scenario, we're doomed to fail. And so having good prospective markers that before, like you showed data where calprotectin will rise before the patient starts to complain of symptoms. And that becomes very important to intervene at the right moment where we can turn off the inflammation before it's gone too far.
Right, so I think about pediatrics, we're about not doing too many tests. You actually mentioned that, is there really a role for small bowel imaging in a pediatric patient who you've endoscopically assessed that they have small bowel disease and they have colonic, and the difficulty sometimes of doing MR enterography in young kids, for example, they drink a lot of contrast. They use, stuff to actually freeze, paralyze the bowel in a sense, so it's very uncomfortable for them. Where do you find the role of imaging in pediatric patients? So where do you best see the role, and where would you advocate, or what have we learned from today how people are using in small bowel imaging?
So I think it's the same type of concept of personalized medicine, where you don't need to do all the tests in every patient, but you need to do all the right tests in any given patient. Okay, and so if we're talking about a patient like one that was presented today in one of the discussions, a patient who everything seems to be going right, but why isn't this child growing if everything else is responding? And you talked about your study where you drop a capsule and all of a sudden you say, wow, there's rip-roaring small bowel involvement. There is activity that I didn't know about. So we need to take all the clues, the growth data, the laboratory data, maybe some non-invasive markers, and really know our patients. And as you talked about, and advocate, have our patients know us and know how to talk with us and back and forth. And when it's not going right, that's the time to do a test. When there's something that I need to figure out, that's a great time to look deeper into the situation.
So we've identified that children behave a little bit differently. They have a few different phenotypes in the adult cohorts that we see. We know that non-invasive use of testing is important in pediatrics. And growth, you had mentioned, really differentiated. Now, Dr. Francisco Sylvester, is really interested in growth. So what did you take away as a way of an education or teaching point about what Because I find that's one of the most unique things that a pediatric gastroenterologist would really need to pay attention to versus someone whose growth plates have closed. So is there a role of growth hormone? How should we be monitoring growth? Are there best ways to assess for growth failure? When does an endocrinologist need to come in? You know, what do we know about how to optimize growth in the pediatric
Yeah,
patient
I mean, those are really important points, and they bring in, I think, what Francisco Sylvester did a very good job broadening the discussion. Like you and I have just been talking a lot about the illness. What about the wellness and a lot of the important factors, growth and well-being type factors? So monitoring both linear growth, but he also talked about bone health and recognizing that the strength of the bone is influenced by physical activity and the force of muscle pulling on bone. So getting our patients out there to exercise can actually be a very important factor in bone health. Monitoring vitamin D levels, and he advocated doing that around this time of year, end of winter, early spring. Being very aggressive at replacing vitamin D, keeping it above 30, and that you want to measure the 25-hydroxy vitamin D. Even though the 125 is the physiologically active component, you want to measure the 25-hydroxy, keep it above 30, and you may need high doses, even 50,000 units once a week for 8 weeks to replace a patient who's less than 20. He also talked about DEXA monitoring and knowing if you're going to do a DEXA scan, you want to do a Z-score, not a T-score. T-scores are invented for postmenopausal women, and a lot of technical reasons why that won't be a meaningful test in an adolescent. Or actually, he talked about using Z-scores up till age 50. So those are all important points about monitoring bone health. He also talked about relationships and sexuality and growth and development from the standpoint of secondary sexual development as well in our patients, and how that's a very important factor to monitor in the wellness of our patients and how they're getting along as they emerge through adolescence. You know, adolescence is a complicated enough time without IBD. Certainly with IBD, we need to become comfortable talking to our patients about these issues.
Yeah, there's also, it's interesting, there's a lot of debate, as you know, about what's the best. Once you've chosen your patient population, you've said, you know what, you've got high risk for developing a complication, or we feel that your disease is one that has a higher likelihood of going to surgery earlier or at some point, and about choosing the right therapy. There was a lot of debate today about enteral nutrition versus straight going to a biologic in a patient who's got growth failure presentation, who's got pretty significantly deep ulcers, has small bowel, large bowel, pubertal delay. What do you take away on all this discussion about enteral nutrition? Because I think a lot of people feel this is a very pediatric approach, and in Europe and in the UK, and in Australia, it's actually almost like there's not really much discussion. This is their induction therapy, and I think there's more discussion on the maintenance side. I feel in the US, with the exception of a few centers, we're very focused on medical therapy.
Yes.
So where is the unknown? What drives that uncertainty, and why aren't people using enteral nutrition more commonly for both induction, and then you could speak a little bit about to the data on inconsistencies in maintenance?
Right. So I think you're exactly right. In a lot of ways, nutritional therapy is the forgotten therapy. It's certainly not by our patients. They all want a diet. They all want to know, what am I supposed to eat? And if I take away food and just put you on liquid formula, and it could be a polymeric formula, something that's very drinkable, like an Ensure, Pediatric peptide, that type of formula, I can put your Crohn's into remission with mucosal healing data behind that statement, as effective as steroids. So you're right, in many parts of the world, corticosteroids aren't even in the lexicon in the pediatric gastroenterologist. I want to put you into remission, I want to induce, I do that with nutrition therapy. Very large signal to us that there's something about our diet that perturbs what's going on in the gut and helps fuel what's going on with inflammatory bowel disease. Too complicated for us to know any one food, a group of foods to remove or to add, but I know if I take them all away and just put you on liquid formula, I put your disease in remission. Your point, though, is once you're in remission for that, what's going to be your maintenance strategy? And there's certainly some data out there that I can maybe liberalize your diet a little bit and give you 80% of your calories from formula and 20% by regular diet. It's a retrospective study from the Children's Hospital of Philadelphia. It certainly needs to be replicated, needs to be prospective, and it'd be great if there could be some real mucosal healing data with that, because we don't really know if those patients stayed in remission. But they did grow, and you know, it's encouraging. There's been data out of Japan also, and this is in adults, showing long-term maintenance or the possibility of long-term maintenance with this therapy. So I think sometimes people think about it when all else has failed. Maybe it's also a therapy that people can think about even earlier in their treatment paradigm.
So I think it perfectly leads into the next topic, which is fecal transplant, because we understand the concept that our diet changes our microbial environment. I think that's been around for a long time, and we know that even within 24 hours with enteral nutrition, the microbiome completely is changed. So we know our food is related to our microbial environment. But there's so much discussion about the role of fecal transplant. And I think that especially in pediatrics, where there's a concern about the safety profiles associated with being immunocompromised or immunosuppressive therapies, biologics, and the role of risk of lymphoma and infections, a lot of families are looking for a more natural approach, and that's where the enteral nutrition seems logical. That is almost like you can appreciate that, you understand that. But what, at the end of the day, right now, where we sit today, what is the stance on fecal transplant in pediatric patients with Crohn's or ulcerative colitis?
Right. So it is so interesting. In a way, it's a commentary when we talk about risk and how our patients evaluate risk, that they're willing to run to stool because they're so scared of the drugs that we end up talking to them about. I think there's a commentary in that. What does the data say? The data says that there's strong evidence for this treatment in Clostridium difficile infections, but there's no real evidence of using it in inflammatory bowel disease yet. And in fact, there have been limited experiences, some of which have shown patients having febrile reactions to the therapy, and there's even anecdotal experience of some patients that seem to get worse after the therapy. So there's no doubt we're going to perturb the gut microbiome with fecal transplantation. Which way are we pushing the microbiome, and is it towards more disease or less disease? It really may come down to what sort of bacteria are we playing with and understanding the microbiome of the patient and of the donor. Certainly there's guidance from regulatory agencies if you want to set this up for C. difficile treatment, and that needs to be followed, but only through a research protocol that's very carefully thought out should this even be thought about in the pediatric IBD patient.
Yeah, because I think there's an increasing concern that there's actually a safety risk with, if you imagine someone with very deep ulcers in their colon or pen, colonic disease, giving more bacteria when you have this very leaky gut, I can imagine that it can actually cause translocation and have some side effects. And there's a group in Europe that suggested that patients were worsening. So I think there may be a phenotype, or it goes back to the beginning conversation, there may be a subgroup of patients for whom fecal transplant may be appropriate. And in certain conditions, and I think the future is really maybe going to be targeted microbial, giving back what you're missing or what you have, or taking away what you have too much of. So it would be a more targeted probiotic in a sense, but very focused on what someone's bacteria is making too much of, maybe short-chain fatty acids, or if there's an actual metabolite of the bacteria, that may be even more of interest than just generically giving, someone else's bacteria. Because I think what people don't understand is that IBD is not an infectious disease like C. diff, where it makes sense to give someone a bunch of stool that has no C. diff, right? That makes sense to someone who's infected. But what makes a genetic disease whose reaction is to commensal flora the advantage of giving someone else commensal flora without knowing whether we may have the same commensal flora? It's not a pathogen. I think that's where the sense kind of stops. Like, people are trying to relate it as if it's an infectious disease. Does that make sense what I'm getting to?
Yes,
Yeah.
no, absolutely.
So I find that kind of interesting. And I think what drives people, maybe one last point, which I think is really important for our audience to appreciate, is what drives people to want to do nutrition or microbial or fecal transplant is the fears of the risks associated with our therapies. There was a paper recently published by Dr. Hyams from the group of the risk cohort that we're all a part of, funded through the CCFA, that really focused on what children get for Crohn's within the first 3 months, and which actually impacts the long term. 1 year later, what is a pediatric Crohn's patient? How active are they? And it was very interesting because we didn't take into account the risks of these therapies. We just looked at does the use of one therapy or another improve the durability of their disease activity 1 year later. And it showed that early use, meaning within 90 days, it appears that anti-tumor necrosis factor therapies tended to have the most impact on corticosteroid-free disease activity, as well as on height. And that's even over enteral nutrition, and that's over thiopurine. So I find it interesting that we need to start having better conversations with our patients and our parents, which are usually making the decisions, that probably the biggest risk to the child is the disease itself. And I think that's what we're starting to also use for both peds and adults, and we'll talk in a minute about what we learned on the adult side. But it's important to get everyone on that page again, going back to getting everybody on the same page, is that if everyone, all stakeholders involved, understand the disease itself poses the most risk from a safety perspective, and that loss of response to the therapy is probably the most risk associated with the therapy, and to de-emphasize the 1 in X thousand risk of a complication, when we really need to just treat these patients appropriately based on how high the risk is of them having a complication. And when this study looked at patients evenly matched for being one of the higher risk of being a bad outcome over time or riskier chance of being in disease activity 1 year later, it was very clear that as of now, the anti-TNF biologic therapies appear to be the most effective therapies for our patients. And so how do you reconcile risk? Because I think that's a really important teaching point is, are there certain things you do, meaning certain therapies you choose based on age or gender, for example? Would you choose one therapy or the other? And does your conversation change when you think about anti-TNF therapies with the family of a boy, whose son has disease versus whose daughter has disease? So how do you reconcile all that in the 5 minutes you have with a patient to actually get the most important thoughts through when you diagnose?
So risk is a very important thing, and over the years I've come to recognize that the way I was discussing it wasn't sensitive to where the parent was coming from. So take Crohn's disease, for instance. Most of the parents never even heard of the disease when I make the diagnosis. And in a very real sense, a parent approaches their child. What's their prime job? To protect my child. So of course it's irrational, but I think the natural place a parent goes is, how did this happen in my watch? How did my child get a chronic disease? And now they go into uber parent mode. I'm going to protect my child from everything. Nothing else bad is going to happen. And then I walk in talking about all these risks. And so the concept right there is, well, no, we're not doing that because I'm protecting my child. And you've raised the most critical point. The biggest risk is the disease. So let's first talk about the disease and what we know about the natural history of the disease and its impact on growth and its impact on hospitalizations, multiple surgeries. But if we do it right, that doesn't have to be what your child has, and that's what we're really going to talk about today. We're going to talk about how to make your child well, not the risks of therapy. And it has to be a balanced discussion. Of course, it will include the risks, but it's the risks of the disease versus the benefits of remission. You bring up the thought about gender differences, and certainly hepatosplenic T-cell lymphoma was the game changer in how we all thought about our therapies. And it seems very clear that of the 38 well-characterized cases, they all were thiopurine exposed. Some were also infliximab exposed, but not all. And so we're a little shyer about thiopurines in adolescent and young adult males. With that, at around the same time, more reports of skin cancers, other cancers. And so whereas thiopurines were the therapy that we had, we now have other therapies. Methotrexate, we talked about a fair bit. It's an immunomodulator. It's been used for years by the rheumatologists, and I think more and more, certainly in the pediatric GI community, we've been using it more and more. Definitely more comfortable in males than females because it's category X, and so we have to have a very serious conversation about pregnancy and the risk of pregnancy while on methotrexate. So I recognize in my own practice I'm a little more liberal with thiopurines in females and a little more liberal with methotrexate in males. Is that really the best therapy? I don't know, but it's certainly how I'm practicing today.
So I think that kind of what we touched on just now really, I think, talks to the same conversations we have with patients who are diagnosed above the age of 18. Those are real And they're not all of these issues we talked about: fecal transplant, risk stratification, role of nutrition, role of vitamin D. I mean, it's not just for pediatric patients, which is interesting. So I think, I can share with you today also about what are the main areas of focus in the adult side of the meeting. For me, when it comes to treating the patient who has growth plates are closed, that's how I think we as pediatricians who also see patients above 18, because you follow kids through college as well, it doesn't just end at the age 18, is that our mindset shifts a little bit. We try and teach more autonomy, we try and give them more control over their disease. We don't have the parents to start talking about risk, and some do, but we really try and bring strength and autonomy to the patient. So I think all of the issues we discussed are really the same, with the adult cohort. What's unique about maybe the adult cohort, which were highlighted in at the meeting as well, was first we'll talk about maybe pregnancy and fertility and health maintenance. That I think, even though I will tell you health maintenance is important in pediatric patients as well, right? We need to be monitoring for vaccines, vitamin D, bone density, skin check should not be just something that occurs. It's interesting, we kind of like put this line in the sand that, for our adult patients, we're doing, X, Y, and Z. Vaccines-wise, I think we're in the same boat, whether we're managing an adult or a pediatric patient. The varicella vaccine status. Zoster remains on the adult side, but in the varicella, we talked a little bit about today, that was one of the questions, and still remains on the adult side, is that one of the things we're finding is that if people were vaccinated, and a lot of our adult patients, especially our older patients, were not vaccinated for varicella, and therefore maintained immunity just through either their child who had chickenpox and they acquired it, or they had chickenpox as a child, and that we're finding that there's not an insignificant number of patients who don't have immunity to varicella, for example, and these patients need immunosuppression. They need more than 20 milligrams of steroids, they need thiopurines, they need methotrexate, they need biologics. So we encounter the same thing in the adult patients. We all need to be checking varicella status. We all should know, because a parent who's not immune to varicella and has a child who has chickenpox and they're on combination therapy, that is potentially a very serious outcome, and we need to know if they're being exposed. So do you find that in the pediatric cohort, that's something we should be also focused on?
Yeah, we're entering varicella is a very interesting problem, because we're entering a whole new cohort, as you mentioned. So whereas it would have been I got varicella wild type, now we're seeing people growing up who are all immunized for varicella. And the commercial assays are not effective at picking up vaccine-acquired varicella. So if the CDC recommends that if you have documentation of 2 varicella vaccines, that's good enough. Of course, it helps if your titer, a positive titer is a positive titer. A negative titer in a patient who received vaccine may or may not be informative. And as our 10-year-olds become 40-year-olds, who's going to have the records of whether they got 2 vaccines or not? So I think it's actually an excellent research question. How at risk are our patients, and do we really know what the vaccine titer means in vaccine-acquired varicella versus wild type? It's a whole new question that we've discovered for ourselves since we've started immunizing patients. Yeah. But the bottom line, as you said, is err on the side of caution, and if there's any question, immunize and get that done before you start your immunosuppressive therapy.
I mean, Dr. Wong noted in her talk that it's about 4 weeks after you give a vaccine. You have to wait about 4 weeks with the varicella vaccine before starting immunosuppression. And similarly, if you had received a patient who received drug in the past, you would want to have a washout of a signal. We don't know quite what that washout should be before you actually immunize them with a live vaccine. But hepatitis B, we're similarly facing both the adult side as well as the pediatric side, that even though many of our pediatric patients got hepatitis B vaccination, I'm measuring, it's now part of quality measure to assess their hepatitis B status prior to starting a biologic. I would have to say that 7 out of 10 patients are no longer immune to hepatitis B. It's pretty amazing. And so on the adult side, we know that the literature also suggests is that part of the reason why I mentioned the quality measure is that it's going to be kind of part of your assessment of your patient, tied to reimbursement, et cetera, is that you need to be checking their status. When you're doing your PPD, prior to starting someone on biologic, hepatitis B status will also be important. The good news about hepatitis B is it's not a live vaccine, so you can start that and continue it and start the therapy at the same time. There was a presentation that was actually done that showed, even though it's good that it's not live and you can carry it out at any time during their biologic exposure, they actually showed that the effect of the vaccination is much lower as they're into therapy a lot longer, and that you want to kind of revaccinate almost immediately upon starting the biologic therapy. So not only is it important to check, but it's also important to vaccinate a little bit sooner. So Dr. Wong was really focused on health maintenance, and she talked a little bit about cancer risks. So do you have your pediatric patients get annual skin checks?
I can't say that that's a routine.
On thiopurines in particular,
right.
sorry.
So more and more on the thiopurines I have. I certainly wouldn't say our biologic patients, I'm as dogmatic with it, but it's a good point.
So it's interesting, as opposed to, and the lymphoma data with thiopurines suggests that when you stop the thiopurine, your risk of lymphoma goes back to baseline. And really the people who are most at risk are those who are on continuous dosing. And that's been shown in the SAM data, and then at the last year at DDW, the VA also showed that. And yet skin cancer is different. Thiopurines, there's DNA breaks, so mutations, and it tends to be that in the same cohort they looked at with lymphoma, that skin cancer does not revert back to baseline when you stop the drug. It's actually any exposure, either continuous or prior exposure and then discontinuous. So something's a little bit different with skin cancer, and then the whole story about IBD alone having an increased risk of melanoma. Not just adding therapies, but just the fact that you have IBD has an increased risk of melanoma. So it's getting me a little bit more intrigued about skin monitoring and being a little bit better. What about the HPV vaccine? Is that something, we tend not to think about it in pediatric, but yet we want to do it early, we want to do it before they're sexually active, so that is, our area of when we're dealing with pediatric patients. So it's approved down to 9 for both males and females. Right. Are you encouraging, like we are in the adult patients, encouraging HPV vaccination?
Yeah, we definitely are, and the American Academy of Pediatrics has recommended it, and certainly in my practice area, our general practitioners, pediatricians, family practitioners have actually been very good at keeping our patients up to date. There's also good data to show that even if you're on a biologic, you'll respond. So as you said, catching up, that's certainly a vaccine that can be done and it should be done.
Yeah, because and Dr. Wong mentioned in terms of regular pap smears, because there's been evidence to suggest that IBD alone is associated with abnormal cervical cells, and then when you start adding immunosuppression, there's increased risk of abnormal cells and obviously dysplasia, and we're wanting to minimize cancer, cervical cancer risk. So in terms of getting on the theme that was health maintenance, talking a little bit about HPV, Dr. Mahadavan was very focused on pregnancy, fertility, and breastfeeding. And I think a lot of the message I got out of her discussion was that, one, you need to treat the mom. The mom's very important because the health of the baby depends on how healthy the mom is. And a lot of people are very, try not to use meds during pregnancy or use the least med possible so that they don't impact the baby's development. So this has been an ongoing discussion for so long. Part of it is because you mentioned methotrexate was category X before, but thiopurines are category D. So category D, if you look at it, any OB, especially the conversations with our patients, is that it's a category D. That means that there's potential harm to the baby, and it must be really effective for the mom to overcome, the harm to the baby. And OBs get very nervous at category D, and so do parents, because they're advised when they first go in and say, you should be on meds that are category B or A, right? And I have patients who come to me and say, my OB said it's okay if it's under B, or if it's B or A, and that they told me to stop my thiopurine, and they were on thiopurine monotherapy. The good news is, and I don't know if you communicate this, because I do get when I manage my pediatric patients, the moms or the parents say, will this impact later fertility, right, or will this will the baby have abnormalities, because they read about category D. But what's nice is that we've had so much data now really in the world of thiopurines that it does not appear, and this is what I tell them, is to stay on their medicine, that it does not appear to increase the risk of congenital malformation. So are you also
Totally.
telling
Yeah.
that conversation?
And it goes back to our previous discussion about the risk of the disease versus the risk of the therapy. As you said, the most important outcome measure for the health of the baby is the health of the mother. So to stop it and have the mom flare during pregnancy would be a sheer disaster and an unfortunate circumstance.
Yeah, because I do a pregnancy clinic once a month with our OBs, and I'm listening to what they're telling the moms, and they're saying, you got to treat the mom first. Like, even when I ask, can I do an MR? I'm always like, should I do this? Should I do that? They're always, treat the mom. It's very important. So that's what the high-risk OBs are really about, treating the mom. And that's where it's important to often partner with an OB that is focused on understanding the risk of therapies and not telling our patients. So Dr. Mahadavan was really focused on the team approach. If you're a high-risk patient because you're on therapies that could be viewed as high risk, it's important to have a really important team approach. And then she talked about biologics crossing the placenta, because that is really buzz, right? It's like, well, if we're not worried about congenital malformation, because it doesn't appear to be the thiopurines, which was the one that had the most hype about congenital malformations. And then we learned that biologics don't really cross, particularly adalimumab and infliximab. This doesn't apply to certolizumab because of the pegylated. It does not appear to be crossing at the level that adalimumab and infliximab do. Because it's an IgG subclass 1, and it preferentially crosses the placenta in the 3rd trimester. And in Europe, they actually stopped treating the biologics at week 22. And they said that they have good outcomes, that moms aren't flaring. But there's a lot of debate, I think, here in North America, which lends itself to the debate, is our initial work suggested that if you stop infliximab around week 30, 31, and then give their infusion immediately post-delivery, because the postpartum is very stressful, and actually, because of the hormonal changes, could be a risk for disease activity. So we often are managing patients, and we move the infusion schedules around so that they get their last infusion around week 31, 32. The complexity, which Uma brought up in her talks today, was really about adalimumab, because you give that every 2 weeks. So it's become a little bit more complicated in deciding how to manage patients who are getting drugs that aren't perfectly 8-week intervals, so we know exactly when to give their next one. So the same will be with vedolizumab. Vedolizumab, I believe, will be getting a category B because it's also an IgG. So it will similarly cross in the 3rd trimester, and it's every 8 weeks. So that maybe we'll be able to adjust similarly. But anything that's Q2 week, Q4 week, Q2 week, and then maybe weekly if you're on weekly. You know what I mean? It gets complicated. So she brought up a lot of interesting points about how there's no real answer and we just have to treat the mom. And that comes down to what I think it is that a healthy mom equals a healthy baby. Other things that were really up for discussion, which is I love seeing people talk about and debate, is the management of the post-op patient. So what are you doing, so I can kind of see whether peds and adults are kind of merging on their thoughts about managing? One, do you believe that all patients post-operatively should be on something? Two, do you believe that every post-op patient should receive an endoscopy at 6 to 12 months to decide whether they should go on therapy, or at least to see if the therapy is working? So what do you do in your practice?
So I definitely do a look after surgery. More and more, that's 3 to 6 months as opposed to 6 to 12.
Okay.
Yeah. So I had too many patients at 12 months that had significant recurrence that I was becoming concerned. If a patient goes into surgery on a biologic, to me that's a little bit easier. I don't want to burn that bridge, so I'll continue the biologic. We certainly have good data that that's probably our best agent to prevent post-op prophylaxis. Does every patient need to be on a biologic post-op? I don't think so. So some of it depends on how long they've had their disease, how long it took for them to come to surgery. So in a sense, how aggressive do I feel their disease is? I do try to keep everybody on something post-op. For a lot of patients, that's what they went on, and for other, into surgery, what they went on. And for some patients, they want to just be on a 5-ASA and take a look and let me see if I really need something more. And certainly that's the patient I'll look at 3 months. If they're just on a 5-ASA, or let's say Flagyl is metronidazole data, then I'll say, okay, that's fine, we can do that. But then we're looking at 3 months and making sure if there is a recurrence, we hop right on.
So it's interesting you say 5-ASA, the data is limited to nothing on the role of 5-ASAs, yet patients feel that I can use something mild, because you just took all this out. I don't want to go on anything that was like immunocompromising again. That didn't work before. There's a lot that goes into our conversations. But there's some interesting data that we make our discussions, and Miguel Reguero brought up an important point. He says, are we really using biologics on everybody based on one study of 24 patients? So he actually showed a slide of, there's more than one study that has actually looked at anti-TNF therapy in the post-op setting, and all of them have shown similar results that he has, that if you use it early and not even wait for the 6-month endoscopy or wait until a patient has clinical symptoms, that endoscopic recurrence was 90-ish% when you use anti-TNF within 4 weeks of surgery. And then as you went to waiting even 6 to 12 months, that went down by half. And then when you wait till the patient has symptoms, it's too late. The efficacy of therapies at that point are much lower. So there was a study called the POKER study, which was done with adalimumab, based out of Michael Kam in Australia, was the PI on it. And he started doing something a little bit more to what we were talking about at the very beginning, which is stratifying patients based on risk to decide what their post-op course is going to be. So there was a suggestion that people who were first surgery, non-smokers, and didn't have internal penetrating as a reason for surgery, those were considered low risk. And then those that were smokers, had more than one surgery, or had penetrating, so internal, like fistulizing, they were considered high risk. And those low-risk patients were essentially, everyone was put on Flagyl or metronidazole, and they underwent an endoscopy, and the thiopurines were added if they had issues, and then biologic if they failed that. The high-risk group actually were placed on either a thiopurine, and if they were intolerant to that, they would go on an anti-TNF therapy, and then he scoped at 6 months, then looked out at 18 months which patients had the best outcomes. And those patients who were on an anti-TNF therapy in the high-risk patients tended to have, as long as they were put on it within the 6-month time frame, they ended up having better 18-month outcomes. So there's more evidence that it goes back to that your underlying risk should drive treatment decisions, and that we can't put everybody into one category and say you all need anti-TNF therapy or you all need antibiotics. So it kind of merged with what the PEDS meeting was talking about, that risk kind of defined. So are you in someone who was on a thiopurine and they say, I want to take a break, and the patient is deciding that they want an endoscopy, and you do an endoscopy, what on the endoscope actually makes you decide on which therapy you're going to use for the maintenance or post-op?
So there's the Rickert scale, the Rickert scoring system, and 0-1 is okay, 2 and above is not. And although I'll tell you, depending on what therapy I'm using, if and as you mentioned, the risk stratifying. So if I have a patient who I was really worried about, rapid progression to surgery, internally penetrating complications, a bad actor, and they've elected to go on 5-ASA, and I can't convince them for more, and I look at 3 months and they're ready a Rickert's 1, I'll try to convince them to escalate therapy at that point, and if not, I'll look again faster. So, a 3-month and then a 6-month study, and see if there really is progression there. So I try to work with the patient and do what they want to do, but we set very clear guideposts of how we're going to monitor it and make sure you're not progressing. So it becomes a collaborative between the doctor and the patient.
So mucosal healing obviously is always a hot topic. We talked a little bit about what's the target. So Dave Rubin and Uma debated the whole concept of, do we treat to mucosal healing or clinical symptoms enough? And even though these debates take place, at the end of the day, I think we all believe that, especially in a UC patient, that achieving at least at minimal endoscopic improvement or macroscopic healing, which may not be histologic healing, but for the purpose of what we mean by mucosal healing as of now, is macroscopically. So how deep are you going in defining your goals? I think we all agree, as I said, even if they debate that clinical is all you need, I think we all agree that some kind of assessment of mucosa, whether it's calprotectin or whether it's some other way, including looking at the mucosa. How deep do you go in terms of defining your remission strategies with your patients?
So again, it really depends on the patient. In a Crohn's patient who has normalized their labs, they've started to have growth acceleration, I'm not as inclined to do a mucosal exam. In a patient who hasn't had that robust of a response and isn't on what I consider optimized therapy, and I need to maybe bring the family along with me, I find a picture of still inflamed bowel very convincing, even for the layperson. So it's interesting that we haven't all bought into it, but certainly our patients have. So again, it becomes a tool in the box. It becomes a part of the armamentarium. There's going to be a study presented at DDW that shows that if you're going to talk about mucosal healing, you really need central readers. You know, the PROTECT study in pediatric UC, which is a prospective translational study of ulcerative colitis with a treatment arm to it, shows that comparing central reading of ulcerative colitis endoscopies to the local reading, you get a very divergent read. So I think we all like the concept of mucosal healing. I think the reason we can still debate it is how do you really affect monitoring of it, and what's the definition is where the tire meets the road.
I think what Uma was trying to say too is she said, so far, even our best studies, we can achieve mucosal healing in everyone, but I will say that Bill Sanborn recently shared with me that they're putting together, that they have data that if you have a patient on a certain dose, if you look at 6 months and you're able to adjust because the patient does not have mucosal healing, that they were able to get up to 70% of their patients healed. So it looks like, if again, it goes back to our discussion about optimization. But I think the other thing that mucosal healing, because that was brought up today, also Fernando Villegas and the surgical colleagues were talking about the role of polyps and dysplasia. So I think part of our discussion about mucosal healing is, does that translate to less dysplasia and less colon cancer? That has never been proven prospectively, but people have, I think, bought into the concept that in UC in particular, the reason why you should monitor them closely and try and get patients on the same page about at least significant improvement and maybe no histologic inflammation is the concept of dysplasia. And they talked about how low-grade dysplasia, it's not necessarily, that's a big debate. It's not necessarily a definitive colectomy, and the difference between an old term of DOM versus a polyp. I mean, you don't see as much of that in the pediatric group, but we do have patients who've had disease more than 8 years.
Absolutely.
I mean, if they got it at 6, at 14, you're doing, how frequent are you screening them?
So yeah, after 8 years of disease, both Crohn's and ulcerative colitis, we're doing colonoscopic exams. Depending upon the quality of the prep and how clean the exam is, either 1 year or 2 years, we'll bring them back. And I think you're right, it's sort of interesting. It comes 360. We may ultimately be able to convince our patients to escalate therapy out of their fear of colon cancer, while we're finding it difficult to convince our families because of their fear of cancer, you know what I mean?
Great.
So it's going to be interesting if we can really prove that continuum of turning off inflammation protects you from colon cancer.
Yeah, I mean, their debate was really about whether an adenoma is reason for colectomy, and there's increasing evidence that a single adenoma, that clear margins, you were able to take it all out and there's no margin of disease around it, the fact that you can just remove it and follow that patient, and that doesn't mean colectomy. So I think that's an emerging discussion that has really been consolidated, and I know that there was a consensus conference recently trying to figure out this whole dysplasia thing, because even though people debated about it, it's still a risk, and people have to really decide, is colectomy that bad to overcome? Do I really want to play roulette with even forget high-grade dysplasia? We know that that's something we're sending for colectomy, but what do you do with low-grade dysplasia? And I think that still remains up for debate, and I know we have debates about it, but I don't think there's really a good answer to that. And the last The last piece, which we'll touch on, is whether or not, it really goes back to the post-op question. One of the other topics was that medications should be stopped before surgery. What's your take on whether or not people who are on immunomodulators or on biologics, should they be stopping those before the surgeon? Like, I've had people call me and tell me my surgeon won't touch this patient because they've just had infliximab 2 weeks ago. Patient needs a colectomy. So do you ever come to that, or are you kind of explaining to your surgeons that the patient needs to be operated on?
So as you know, there are studies that look at this and they're sort of divergent in their findings, and I think, at least my read, at the end of the day, it comes down to the nutritional status and the overall wellness of the patient. So the patients who are on, let's say, biologic, and they keep hoping it will work, and so they should have had their colectomy 3 months ago, and they're getting sicker and sicker and sicker. Those are the ones who are going to have complications. So I think you're absolutely right. It's more important to get the surgery done than to worry whether they're on the medication or not, and allow the patient to deteriorate while you try to get them the way the surgeon wants them off a medication. I don't think that makes sense.
Yeah, I mean, I'll tell you, just in the last point, is that it does not appear to be that the thiopurines and the biologics are increasing post-op complications in general, but steroids are a problem. And I think the fact that people keep waiting for biologics to occur, and then a UC patient, the whole discussion, because there was patients who underwent colectomy who had pelvic sepsis, and there was significant morbidity associated with that, is that they thought it was related to the infliximab use, and they made a blanket statement that they do 3-stage surgeries instead of 2-stage if they were exposed to TNF. And you really have to think about the steroid exposure in those patients, because they were probably exposed to long-term steroids.
Sure.
So I think that debate will continue, and I think what it comes down to is, when we think about everything we've talked about today, we really, to summarize, we talked about stratifying patients, monitoring patients, getting patient communication up to par, understanding the risks of the disease versus the risks of, and more so benefits of the therapies. I hate to focus on risk, but risk-benefit conversation, being aware of what does mucosal healing impact both outcomes, short-term as well as long-term, and making sure we're communicating how to actively target the disease appropriately and really treat. We talked about treating the mother, treat the patient. If the patient needs surgery, take the patient's surgery. So I think, but it all comes down to is we all need to communicate, right? It's about communicating to the OB, communicating to your surgeon, communicating amongst each other, and communicating to the patient.
Yes, it takes a village.
Okay, right.
You're right.
So I want to thank you very much for joining me today in
Thank
our
you.
Expert Perspectives, and I'd like to thank everybody for joining us for the Expert Perspectives from the Great Debates and Updates in Inflammatory Bowel Disease meeting in San Francisco. Thank you.